I'll just briefly introduce our very honored guest, Dr. Joe Gemsek. He's the founder and medical director of the Gemsek Specialty Clinic in Washington, D.C. Dr. Jemsek is a board-certified physician in infectious disease and internal medicine. In early 1983, he diagnosed the first case of HIV/AIDS in Mecklenburg County during an infectious disease consultation on a young male dying with atypical pneumonia. He went on to provide care for more than 2,000 individuals with HIV/AIDS through to early 2006. In 2000, he founded a specialty infectious disease practice with the goal of serving patients with HIV/AIDS, in addition to general infectious disease, including Lyme Borreliosis complex. And of course, that now includes COVID-19. He's seen a lot of patients, and he's very, very kindly offered to come back again after a month, and he'll purely be answering questions today rather than giving a presentation as well. We do have a lot from last time, as well as new questions that have come in. And please do use the Q&A button at the bottom of the screen to ask your questions during this call. So, Dr. Jemsek, thank you very, very much for being with us again. Could you perhaps give us a brief overview of anything new over the last month that you've noticed in this crisis that we're all undergoing, and also perhaps tell us a little bit about the Global Lyme Alliance scientific study that you've just kicked off?
Well, as time goes, thank you, Jillian. That's very kind of you, and it's an honor to and privilege to work with AONM. You've always been very kind to me. This is Gemsek version 2, I suppose. Mm-hmm. So as I look at the COVID epidemic and read, hear the news and look at what's happening in Florida and around, I see an undulating pandemic, one that permeates very deeply. I liken it to a bad flu epidemic, although it's not, the outcomes actually, if you look at it, are not quite as severe as a flu epidemic. The problem is that it seems to persist through the warm weather months, unlike the flu, which it portends a lot of trouble, and we don't know what the tail is going to look like. When is that going to happen? We don't know if 80% of our population eventually becomes infected, or as one of your UK physicians predicted, everyone will be infected, which is, by the way, that's what I say about Borrelia, which I think is quite accurate. So we don't know, and then the question is, in a world where we know the virus is going to mutate as it already has, and are we going to obtain natural immunity? And if so, is it going to be effective? And if so, for how long? And what role will a vaccine have in treating people or administered to people who've already been infected? So there are so many questions. I do think there are some rather straightforward things that you can do to protect yourself. And I do think that there's good science for use of inexpensive medications, which are effective if given early in the illness. So we have a whole range of questions from, the sensitivity and specificity of testing, to how often the testing should be done, to whether or not we obtain natural immunity, and if we're reinfected, is that, if you have a second course, is that a reinfection or a relapse? In other words, do you carry the virus? There's some evidence that the ACE2 receptors are really heavily concentrated in the gut, and so forth. Does it stay in the gut for weeks or months? So we have a lot to learn about that. I'm all in favor of using simple remedies, that are simple, effective remedies. I know that the drug industry is cranked up to create vaccines. There's numerous industries working on that, and then very expensive exotic drugs are also in the works. I'm not in love with that, but this is the way of at least in America, of American industry and American pharmaceutical. As far as GLA, Global Lyme Alliance in Stamford, Connecticut, we're honored to be the first ever clinic to do a clinical trial in conjunction with 3 universities, University of Missouri, University of California, San Diego, and Columbia in New York, using Gemsek protocol to treat new patients, following them, doing nothing different in terms of how we approach the patient, but additional blood work looking at cytokines, biomarkers of all kinds, immune markers of all kinds. So that's very exciting. And we've already enrolled 7 patients with a goal of 30. So we hope to conclude enrollment by the end of the year.
Will you be taking,
Sorry?
Will you be taking on patients who've also had COVID, or will you attempt to exclude them just to kind of keep the...
No, right now it's not an exclusion criteria. You know, as of now, it's not an exclusion criteria.
Okay.
So I think the whole point of the GLA is that, you know, we're dying for some science. And you have to marry the clinician with the scientific community at some point. You just do. And this is the first forage into that union. And that's what's so exciting about it. People know that. I mean, we can have, if you have 100 different doctors treating Lyme borreliosis, there are going to be 100 different ways it's treated. And I'm not saying my way is the only way, of course. Everything can be improved, but we get people better. And the key is, can we, you know, with this information, can we start to do even a better job? And then what do the patterns tell us from the laboratory about the course of therapy? Typically, it takes a few months for people to start to turn the corner. We have a process of doing priority approaches to the co-pathogens and so forth, never stopping to treat the borreliosis and all its life forms. We never stop. But we know we have to treat key co-infections as well. We have to address biofilm. And prior to treatment, we know that we have to stabilize the patient. So there are innumerable issues, including the gut, endocrine system, and so forth, psychiatric issues that need to, sleep issues, pain issues, that make this such a complex illness. And those things have to be stabilized to the extent possible. There has to be support from a companion, family, whatever. Patient can't do this alone. So we exclude patients from therapy who can't meet our criteria, or we have to delay it. We've also identified at least 25 different conditions which either preclude or complicate therapy. And those are listed on my website. Yeah, because there's so much going on and so many things that this can do.
That's very exciting, though, especially doing a sort of randomized controlled study like that, where you're not just taking one marker, which is traditional, right, isn't it? Right. Well, I'll start asking the questions that have come in previously to start with, and then we'll go on to the ones that are coming in via the Q&A. Would you say that patients who have had COVID can confidently rely on antibodies to avoid a second infection?
No.
From your experience so far?
We don't know. I would say no, though.
Okay. Have you come across patients who have potentially been exposed to COVID-19 but not developed enough antibodies due to an ongoing viral infection of, for example, cytomegalovirus or Epstein virus, and depleted natural killer cells? In other words, would they still develop antibodies?
I think the more immunocompromised you are, the less likely you make antibodies, because you know, that's the humoral system. You have to go through the B cells, which have to communicate with the plasma cells to make the antibody. We already know that our B cells with Lyme borreliosis, which is life-altering, we already know that B cells and T cells don't communicate very well. You know, we see depletions. We see quantitative depletions in this, which lead to depletions in immunoglobulins, which are not uncommon. And then we see low CD4 and CD8 counts as well. Almost as HIV would be in an early to moderate stage. So I would say that anything that confounds the immune system or complicates or depresses the immune system is going to result in inability to make antibodies. And I think that has at least something to do with why our testing is so poor. You know, serologic testing is a slippery slope. It's the worst, it's the least effective way to monitor an illness where the immune system is involved, because you're making the false assumption that the immune system is capable of generating antibodies on command, and that's just not the case.
It's not, yeah. Well, that answers a lot of other questions, including ones that have just recently come in, so I'll leave those out. Are you seeing any cases of prolonged recovery from COVID? If so, what do you think are the differentiating factors here? Is it ongoing infection or an ongoing immune response?
I would say the immune system is having a lot of trouble putting COVID away. So I would say it's ongoing smoldering infection. And I think we'll see a lot more of that in the future, which is, it's unpleasant to think about, because that means that on some level, these people will remain contagious for more than 14 days. There's going to be a segment of the population that behaves in that way.
Thank you. Do patients who also have Lyme and then contract COVID seem to have a more severe infection and longer recovery?
So it depends where you are on the spectrum of Lyme Borreliosis complex. I would say that if you're, any stress, whether it's an infectious disease or a family trauma or a physical trauma, really disturbs the trajectory of recovery. Let's say you've had a few months of therapy and you're starting to get better, but then all of a sudden you have an auto accident, or all of a sudden you get the flu, or all of a sudden somebody gives you a vaccine that's ill-advised. These things have a chilling effect on the trajectory of recovery in our patients. Our patients need to be coddled as they recover, and they need to continue to have a low inflammatory lifestyle. And, really, our treatment's about a year, but recovery is 2 years. Now, during the recovery period, things are so much better. So don't get me wrong. I mean, it's a much better place. People are so happy. They're healing. They have the opportunity to heal because the infections have been purged for the most part. And as a sidebar, let's be sure everyone's aware that we never get rid of the spirochete, never. Just a matter of changing the whole paradigm so that we have immunologic dominance. But it does take a couple of years. It takes a long time to heal tissues. It takes energy to heal tissues. And especially in the neurologic system, where not all parts of the brain, for example, can regenerate equally. And with patients that are sick enough to take intravenous therapy, I mean, dreadfully ill, I would say recovery is more like 3 years.
Okay, thank you. You've explained just now how having Lyme can affect somebody who also contracts COVID. Do you have any impression yet of the relationship between COVID and ME or CFS patients? I mean, I know that ME is very often driven by Lyme, but that's how the question has come in. So I wonder if you'd like to answer that.
I think
it's not possible to pull them apart.
It's not possible to really answer that accurately, I think, but I think that whether it's ME or Borreliosis, I think they're driven by stealth pathogens, quite honestly. Now remember, we don't just have the spirochete, which is the most facile and of the organisms, also the most biologically advanced, genetically advanced, but we also have some pretty tough organisms that are activated or introduced. So I look at it as a handful of organisms, and then some parasites in the gut and candida and so forth. And they're all pretty tough. And we need our immune system. Here's the deal. We need our immune system to help us. And it's kind of MIA early on. So we do the best we can to plot ahead. So in fact, I said our therapy is a year. far as borreliosis goes, I've made a decision due to the recrudescence of babesiosis in a rather small percentage of patients, but appreciable, 15%, too many, 15, 20%, it's just too many, who will do very well on maintenance therapy or even off maintenance therapy and then relapse. And most of those, if you look, and this is listed on my website, babesiosis recrudescence is number one. So we are changing our protocol. And even though it's unpleasant, once you're into maintenance, year 2, we're going to re-administer a very robust Babesia protocol for 2 or 3 months. The difference being, the rationale being, now we have our immune system in much better shape to help us. So that in the long term, we hope to reduce recrudescence of babesiosis and then recurrence of Lyme borreliosis, which go hand in hand, by 80%.
I understand. That makes sense. Thank you. Is it possible that COVID-19 will become a co-infection of Lyme disease? In other words, actually be transmitted by ticks?
I don't know that it'll be transmitted by ticks, but I think that's a brilliant question. It could easily be a co-infection. I think we don't know whether it persists, and there's some evidence that it does persist. It has places to hide in the gut in particular. And yeah, I think it could be, we don't know, but that's a really smart question.
It's being found in the water supply now, isn't it? In sewage and so on. One just doesn't know. Anyway, another patient asks here, I have low IgG levels and Lyme disease. Is there anything I need to be aware of, or does this not put me at more risk of catching COVID-19?
I would say to that individual, I don't think so. So there's a congenital condition called variable immune deficiency, in which folks are susceptible to encapsulated bacteria such as pneumococcus and Haemophilus influenza, causing chronic and recurrent sinusitis, chronic and recurrent bronchitis or pneumonia, often bad enough to require hospitalizations. Those people should be treated with IVIG. In our population, it's a shame, and this hasn't been published, which is tragic, and we've seen it for years. We see low IgG levels, IgM levels, IgA levels. Sometimes IgM is elevated, as a spike, but for the most part, IgG is reduced. And fortunately, this does not translate. The same thing happened in HIV, by the way. Fortunately, this does not translate to the picture or pattern that we saw with variable immune deficiency. So you're not getting pneumonia every month or sinus every month. And so I think from a functional standpoint, I think the innate immune system does enough to protect a deficient adaptive system so that our folks don't have susceptibility to bacterial infections. And, HIV and Borrelia and most of the other co-pathogens are T-cell based infections. So they're not based on the humoral system, they're based on the cellular immune response. So just having a low IgG, shouldn't cause panic. And above all, you shouldn't run to the immunologist and be receiving IVIG, because that's like taking pooled antibody. What's happening? You're taking pooled antibody from 100 patients, which is, highly filtered and processed. And it's like throwing against the wall and seeing if some of the antibodies actually are anti-Borrelia and will stick. And that's what you're doing.
Thank you. Could you please explain if you think that Lyme patients are potentially more vulnerable to the cytokine storm that appears to be the most dangerous aspect of this new virus?
Well, if they've had a good, they've been introduced to a good, stable supplement program, they're already protected. And later I can review what we talked about before in terms of some of the key supplements and some of my favorite supplements. But without a supplement package, yeah, I think they are more vulnerable. I do.
Another question here, apologies if it sort of repeats that, but just from another angle. I hear you saying that your patients with Lyme borreliosis complex that have contracted COVID have fared as well as the rest of the population, which I think it just depends on the state that they're at, doesn't it? It
Depends on the state that they're at, and
depends on the severity of their disease.
Right, and they're also under my care, not to be immodest.
Okay.
But
this is purely about Lyme. If a Lyme, oh no, it isn't actually, sorry. If a patient with Lyme gets COVID, having had several years of antibiotic treatment, but not yet well, what should we look out for in terms of deterioration?
Really depends on your immune set and where you are. Those are really hard to answer. There's so much variability with both diseases. So you can't give a specific answer there, but it does depend on the stage and your relative immunocompetence. I would say that if you've improved, even though it's taken several years of plodding along, you're in a lot better shape than you would have been at the beginning.
Yeah, and another one here, does Chlamydia pneumoniae increase the pressure on your lungs when fighting COVID-19?
Absolutely, because you can get reactivation of these organisms in the lung. The lung's a big place. Lungs are a big place. So we have mycoplasma, chlamydia, and probably Bartonella and Spark. So your immune system is has a very light hold on these pathogens, and if it's dysregulated and disrupted and becomes dysfunctional, those things can activate, and then the immune system is catching up. One way I like to look at it, because it doesn't make a lot of sense to people, is with the immune system not working, how come there's so much of an inflammatory storm? I think there's similarities between COVID and getting past the adaptive system, and same thing with Lyme borreliosis. So the immune system, it's the worst of both worlds. So it's there, it's dysfunctional, but it's making noise and causing destruction, but it's not controlling anything. You understand? So we get the worst of it, and it's playing catch up in both diseases where they're advanced.
Oh, that's very serious. Yeah. Any advice or comment on how Babesia infection might affect the presentation of COVID?
Babesia is clearly immunosuppressive. I think it blocks TNF. It doesn't allow the body to clean up as it should. And you've heard me say before, I think Babesia is the driver for the expression of Borreliosis complex, and one of the toughest organisms to treat. So if you have active babesiosis, you're definitely at increased risk for a poor immune response. And if you couple that with inherited genetic susceptibilities through the HLA system, you're in trouble.
There was actually a question directly related to the HLA system, which is which particular phenotypes increase the risk of developing therapy refractory Lyme disease, DRB1 in particular. Is that associated with autoimmune phenomena later and a great difficulty in treating Lyme?
It may be. The ones we've identified where the literature supports it, and I'm not a geneticist or immunologist, however, we can read. And so DQA1, DQA2, DQB1 seem to be, if you have homozygous substitutions, you may be in trouble. It would be wonderful if we could advocate for a simple finger stick to test for that, wouldn't it?
Wouldn't it? Yes, instead of having to do such complex genetic testing. There's been a recent link between COVID-19 and autoimmune responses like lupus. Do you see a link there? I think what this patient is saying is they've seen newspaper articles and others relating the two. Whether you see that.
I don't know much about that, but I would say that if you're activating an immune system which is dysfunctional and you're genetically predisposed to have one disease or another, I can see how that could happen.
Okay. Since Lyme causes thicker blood and COVID can cause blood clots anywhere, I'm guessing that's a horrible combination. What would signs of blood clots be in your brain, lungs, limbs, etc.? And what are signs, or how are the signs different according to where the clot is?
Depends whether the clot's in the venous system or the arterial system. So you're more likely to have infarction, of course, in the arterial system. So there are receptors in the brain for COVID, and we all know that there are reports of encephalopathy and, you know, stroke and things like that. Actually, the lung doesn't have the quantity of receptors as other organs do, particularly the gut, but it is the entry point, you see. So doesn't seem to matter. But the coagulation, so the coagulopathy that occurs is something that we'd like to prevent. And, you know, I'm going to talk about nattokinase in just a moment as a very simple and safe way to do that. And I have probably 100 patients already taking it, and hopefully many more online who've begun to take it, and quite safe and good scientific support for it. I'm shocked that it wasn't brought out earlier, quite honestly.
Well, you've mentioned that it inhibits PAI1 as well.
Well, that's what it does, yes.
Could you maybe just explain what that means for those who didn't pick that up the last time you spoke?
So prothromboplastin, you know, breaks down clots. Prothromboplastin activating inhibitor -1 promotes clots. All right, so they're in homeostasis. So, you know, day to day, we don't, you know, our blood vessels and, you know, our clotting system doesn't want to bleed and it doesn't want to clot. So everything's in homeostasis. When COVID gets behind the adaptive system and gets into the vascular trees of various organs, it upregulates PAI1, promoting clotting. And that is, so at first people thought this was adult respiratory distress syndrome with, and some of the intensivists who are generally very, very good doctors, intensive care medicine, although they tend to burn out after a few years. It's so hard, such tough medicine. But anyway, they recognize this is not ARDS. We have patchy infarcts in both lungs. We have, it's, you know, segmental, and it's, you know, it's not a diffuse wet lung. And so then, you know, here comes the pathology, and then we see all these clots, you know, everywhere. So that's how people die. Now, I'll tell you a story of my brother, who's in New England, who had a undocumented but pretty classic COVID presentation with a month's worth of, he's non-smoker, non-asthmatic, of COVID illness. So he was down and out, and he coughed, and he had, you know, malaise and achiness, and then his left leg began, his left foot started to swell, and he ended up with a heel to thigh to groin major thrombus.
Oh no.
I know, is, you know, so I thought he might have an occult malignancy, but of course he couldn't be tested for that. But now I'm convinced it was COVID.
And did he get over that all right?
He's doing okay now, but yeah, he's doing okay now. But he's on Eliquis or one of those.
Well, the second question here related to hypercoagulation was, how do we get rid of the blood clots? This patient says, mine formed in my legs. 1 month on blood thinners, and I still have some big ones, and the doctors here say they won't prescribe anything else.
Well, sometimes it takes 3 months. If it's a deep, severe, it generally does take 3 months, actually. I would leave that up to the hematologist, because you can't give a blanket recommendation for that sort of thing. Okay. So if it's but folks need to understand the difference between deep and superficial. There's a huge difference. With superficial, you can take some anti-inflammatory like ibuprofen or naproxen, hot packs, elevation, and, you know, it tends to get better. Deep is much more serious, whether it's in the pelvis or in the lower extremities. And obviously it can break off, go to the lungs, and kill you.
This is asking about the same topic from a different point of view, but I still think if you have anything further to add, it's very, very interesting. Some medical experts have described COVID as more of a blood vessel disease involving clotting thrombotic microangiopathy, TMA, than it is a respiratory disease. If that is true, what particular relevance does this have for Lyme patients? And is that related to the same hypercoagulation often seen in Lyme?
No, I think they're different mechanisms, but I don't know for sure. Certainly the time pattern for COVID typically occurs after 10 or 14 days, right? That's the time when the adaptive immune system should have kicked in, but doesn't, and it gets past it. And then once it gets into the blood vessels, now there's the catch up, and so there's inflammation and all that cascade, spurs PAI and so forth and so on. With Lyme borreliosis, quite honestly, I've seen 13,000 patients. Fortunately, we've only had a handful with blood clots. We put everybody on fish oil. Maybe that helps. I don't know. I don't use nattokinase routinely until now. I used to use it back in the day when I was trying to gently disrupt the biofilm, because there's certain things out there, Beluca and Wobenzyme and serapeptidase, and I just was afraid to use them because I didn't want to unleash horror on my patients. I didn't know. I knew there was biofilm, of course, but and I knew we should kill what comes out. So to those listening, if you're treating with biofilm or for biofilm, whatever comes out needs to be killed. Because when it comes out, it will convert to a planktonic form, which is a free living form. And what it will do is to go to more cells and kill more cells and make more biofilm. So you get in a vicious circle. So that's why we're very strict about what we use now and telling people you must stay off, in our case, sugar, alcohol as well, in general. So all the artificial sweeteners, which sugar alcohols include erythritol and stevia and xylitol. We happen to use xylitol for our program. But I think sucralose is also causing a problem. Aspartate, I don't know. But that's a strict rule with us. So, people will take, sugar-free this and sugar-free that. You have to realize you're releasing things from biofilm when you do that.
Stevia does do that, doesn't it? Yeah. Would you take nattokinase preventatively or at a specific stage of COVID-19?
I'm giving it preventively until this thing, goes away, hopefully next year, hopefully. We'll see.
Okay, thank you. A question on a slightly different topic here. Would it be safe to start taking testosterone as a transitioning person? I showed up Lyme positive with Ellie spot and ELISA positive with the NHS, but Western blot negative.
I think testosterone's, as long as it's, so again, going back to the hypothalamic pituitary axis, it's very common to have low testosterone, both in men and women, different mechanisms. And testosterone is very important for cellular integrity, energy, muscle mass, and also for thinking cognitively, quite honestly. So by all means, take your testosterone. I don't think there's any adverse pro-inflammatory aspect here.
Will mast cell activation syndrome make COVID even more dangerous due to inflammation in the lungs that you already have?
I tell you what, if the COVID is, past the adaptive system, I think the answer would be yes. Because histamine becomes a pro-inflammatory agent, or is. Histamine's our friend, okay? We all have histamine. It's just that when it gets out of control, it is capable of, getting into a pro-inflammatory cascade. And the reason it's the buzzword these days is that we can see it. We can't really measure it. It doesn't measure well. And the tryptase that people try to order is not very useful. But the fact is, we know it's one of several cytokines. It's one we can see, and for the most part, it's one we can control. So to the extent that we can control that, we reduce the inflammatory quotient, which is all to the good.
Thank you. One that came in a bit later, it does refer to the HLA genes that you were mentioning earlier. When you do have HLA genes that are affecting your immunity, is the adaptive immunity functioning at some subpar level, just not fully? And is there anything that these patients can do to increase their adaptive immunity function?
Well, that's a good question. And so the adaptive immune system is functioning, it's just delayed. And anytime, whether it's a methylation cycle or it's this particular model, anytime you have homozygous variants that are critical in the pathway, the enzymes are still working. It's just instead of at 100%, they're working 20%, 25%. So they're not gone. They just don't work as well. And so when you're genetically at risk, which fortunately seems to be a very small percentage of the population, we'd love to get some data on that. Tried to look for it, couldn't find it. But so if anybody has an answer about, how many of the population have homozygous variants or substitutions in those genes, that'd be great. But they are functioning, and the variable immune system is delayed, so it doesn't respond. We need 10 days or so for the innate immune system to deliver antigen to the adaptive system, and for the adaptive system to shape up and become sharpshooters. And if that doesn't happen, the pathogen gets past that, and then you're playing catch up. And to further answer, I don't know any way to change that, quite honestly.
Well, the second half of this question was, in your Lyme population, is it getting the microbe loads down that could allow the adaptive immunity to come back online in this population with HLA susceptibilities?
Well, I don't know about this population. Remember, that's a small population, but the general answer is yes. So our concept for years has been, first of all, we're strengthening the immune system, so we change the paradigm. It's a slow process. And then after a period of months, it starts to focus, which means to me that the adaptive system has started to kick in. That may take 6 to 12 months. But when we get a strengthened immune system, it's just sort of, our poor patients, we try to balance everything, and we take advantage of the slow replication of our targets so that we pulse and we give time down, just like chemotherapy, right? So we'll see a lot of turmoil, and we know the immune system is strengthening, and we'll see rashes come out that weren't there before. We'll see joint pain come out. We'll see, new symptoms. And a lot of times the patient will be distraught, and I'll say, you know what, your immune system's starting to wake up. And then after a few months, it starts to sharpen, and so the better the patient does, the less we do, because we want to hand this over to the immune system. And so I would say that's what we're looking for. Now, the problem is that we don't often check the immune system afterwards, but in the times that I haven't really seen a quantitative jump. And I wonder about that. I wonder if it's going to take 2 years or 3 years for that to happen. So that's one of the immunologic questions that need to be answered.
But when you say you don't often see a quantitative jump, is that ever the CD57 that you don't see increase?
I don't follow that.
Okay.
I'm an HIV doctor. We had good tests. That's not a good test.
Okay.
Sorry.
One patient here says, I've been battling Lyme and Bartonella for 15 years and have ongoing COVID symptoms 12 weeks out from contracting it. Do you believe that these are ongoing post-viral cytokine storms, or is this reactivation of the virus itself?
I think this individual has an immune system that's really struggling and, bobbing and weaving. If you're still sick after 15 years, you've missed some key points of treatment, namely intelligent eradication of biofilm done in a synchronous way, and aggressive treatment for babesiosis. Babesia lives in biofilm. Okay, nobody, we're 100% sure of that from a clinical point of view, and that's that may be a leading reason why people continually relapse or fail to respond to therapy. In my view, if you just want to give a broad estimate of quality of life, which is hard to do, I think if you don't eradicate babesia and you're doing supplements and you're following a clean diet, maybe even able to do a little exercise or whatever else you're doing, it's just proactive. I still think you only can get to about 60% of a potential quality of life if you don't eradicate babesiosis. I've seen it hundreds of times. So
thank you.
I think I think if I could just add, what the world is missing is how to treat babesiosis and biofilm in concert and do it intelligently instead of just throwing drugs at everybody.
Okay, thank you. Would you add anything further to this question here, or would you say it's similar? This patient writes, I have Lyme and had COVID in April. I got better at the end of May and then got symptoms again 5 weeks later. Does it seem more likely to be a reemergence or a new infection?
A reemergence.
Okay. Will ginkgo work in a similar way to nattokinase as a blood thinner? And can they be taken concurrently?
I know ginkgo can thin the blood, but I don't know if it inhibits PAI. So that would be the key question.
Okay. Is pregnancy higher risk with COVID in the mix on top of Lyme in terms of risks to the mother, the baby, and the pregnancy itself?
We don't know yet. But as an aside, so first of all, if the mother is morbidly ill and happens to become pregnant, I think the risk of miscarriage is very high. I think the risk of miscarriage in this Lyme Borreliosis complex is much higher than the average population. And that's a study that ought to be done. This, there's so many things that we need to look at. Some are hard and some are not hard. This is not hard. But the gestalt is, yes, of course, when we interview patients, they've had more miscarriages. However, if you get into pregnancy and you're somewhat reestablished immunologically, all that estrogen is anti-inflammatory and protective. And if you can get through the pregnancy, postpartum can be very difficult, however, because the estrogen drops to zero or very low. So in our population, we have a procedure which is shared by many of working with the obstetrician and treating with a modest antibiotic program of fetus-friendly drugs, beta-lactam and zithromax primarily, and just treating through pregnancy and then checking cord blood for PCR. And we've had 4 positive out of 200 over the last 15 years or so. It's all about.
I missed that word. You've had 4 what? Sorry?
Positive PCR.
Okay. Mm-hmm.
Yeah. So pretty good. Doesn't mean the infant's not infected, but it's not infested, if you will. It's and there's no congenital findings. So yeah. As far as the effect of COVID, I have no idea. I don't think it would help anything. But hopefully, COVID would be dealt with and not progress to a more serious manifestation. Although we wonder about how long these things persist.
Mm-hmm.
And it'll be interesting to see if there's any vertical transmission of COVID to the infant.
Hopefully, those studies will be done.
I may add the ACE receptors are rather sparse in the female genitalia, so that's a good thing. Mm-hmm. Whereas in the male, the testicle is a prime target.
Oh wow!
Isn't that interesting? So for the female, the receptors are rather sparse, which is a good thing.
Rather detailed patient-specific question here. I suffer from neuroborreliosis and have had Lyme-induced aphasia since being infected. I notice that when I'm tired or stressed, the aphasia really flares up. I was wondering whether there are any studies being done or that have been done on this particular phenomenon. she's worried that it could lead to Alzheimer's while she's in her late 30s, and would just like to know what to do beyond curbing stress to get rid of the aphasia. It's a difficult one, isn't it?
Well, it's a difficult one because so when I talk about Lyme borreliosis complex and I talk about the CNS, I talk about multi-compartmental infection. We all know the brain's connected in every which way, but the only way to think about it, where you can follow the patient, is to put them in compartments. And so in her case, her cortex has been involved. She has maybe the Broca's area is involved. Or perhaps she's talking about, I don't think she is, but perhaps she's talking about an inability to articulate because her tongue is affected either through the cerebellum or through the lower brainstem. But I think she's talking more about just can't get the words out, expressive aphasia, which is more of a cortex thing. But I can guarantee you that there are other areas of the brain that are infected. This is just a dominant issue. And our patients with borreliosis are so susceptible to stressors, daily stressors, that it can easily evoke the symptoms. It's quite unfair, honestly. And she just has to work doubly hard at detoxing. The better you detox, the better you'll do. So when we talk about our patients in treatment or on no treatment, if they have, it's all about the toxin level, which we're not really able to measure. Hopefully the GLA study will help a little bit with that. But I can tell you, you're not killing, another billion neurons, or you're not building another billion neurons. It all has to do with the level of toxins. If they're low, you have a better day. If they're high, you don't.
Okay, thank you. Some questions here relating to NAD and NAD+. Do you have any thoughts on those, and whether they could help with this new virus?
Well, those are reducing factors. NAD plus and nicotinamide, they're the same thing or similar. They're reducing factors which drive to NADH, which is important for electron transport function as coenzymes, which generate more ATP. And what you're doing is upregulating the energy and activity, which it's debatable as whether that's a great idea. If you're in the middle of an inflammation, I'm not sure that's a great idea. I think the focus should be on antioxidants. And I hate steroids, of course, but there is a role for steroids if somebody's in extremis in the ICU. That's when I would use it. You may have seen the report where people became very excited about an old drug, dexamethasone. Well, that's horrifying. That's horrifying. But NAD, so we do a lot of genetic analysis and reports for our patients, and we think nicotinamide is an efficient way to promote the electron and reductions and drive the electron transport system. It's one of many variables, but it's not going to be a savior in somebody that's inflamed, extremely inflamed, especially with COVID.
It's very interesting that you suggest that perhaps it's not to be used, in fact, when somebody's going through a cytokine storm, right, to drive it further. Yeah. Are those, this is a more general question again, are those who've been diagnosed with Lyme but have only had fairly mild symptoms equally at risk as those who are more affected by Lyme borreliosis?
Probably not. I would say that the people that can function at a higher level, treated or untreated, are just using modifying factors such as supplements and so forth and lifestyle, suggests that their immune system is more intact. So few people in the world have access to quality care. The standards for care have not been established. The GLA study is a baby step in that direction, perhaps. But there are a lot of things you can do, and everybody's learned about them to alter your lifestyle. If you look at the least in American television, it's all about infomercials on this supplement or that supplement and getting your life back, or, you know, mattresses and beds and, you know, getting more sleep or exercise and so forth and so on. And it's just, you know, it's just, you get the overwhelming sense that everything, you know, there's so many people that are unwell and, you know, want to feel better. And of course, gluten is a phenomenon that hasn't really been thoroughly discussed and open in, you know, in an open way. Why is that? Well, you feel better, you know, so people do it by steps. If you don't have access, you don't really know what's going on, just by, you know, going through the process, you may say, well, I feel better off gluten. And then later on, I need an extra hour's sleep and then I feel better. If I don't get it, I don't feel better. Or I need to ride my bike 30 miles a day. If I don't, I have a bad day because, you know, they're detoxing and so forth and so on. It's just in this supplement, that supplement. So you're trying to keep yourself in neutral in terms of your oxidative, you know, pathway. You're just trying. And you've got borreliosis driving things the other way, is a chronic inflammatory storm. If it's mild and you can compensate, great. But then there comes a tipping point. It may come in small stair steps, or you may fall off the cliff if something you know dramatic happens to you. So I think that's a broad way of looking at what's happening to our society. There's way too much illness. There's way too much MS. There's way too much, you know, all of the neurodegenerative diseases. Way too much. I mean, what in the hell is going on?
Yeah. Maybe you could just review the kind of miracle cocktail, as it were, that you mentioned in your first talk to us, specifically for COVID, that you've identified now as being perhaps the very best. I know one has to be tailored to each patient, but maybe you could just perhaps go over the key remedies that you have found useful that don't drive further the
Right.
cytokine storm.
So the CDC put together some very simple recommendations, and then we found nattokinase because we said, okay, you know, if the fatal consequences are due to coagulation, you know, what can we do about that? And so the CDC started out with vitamin C, 1 gram twice daily. Doesn't matter whether it's ester or liposomal. Vitamin D3, 5,000. This is for the adult male or female under 60, for example. Then we have zinc, 50 to 100 milligrams. 100 milligrams for somebody over 70 kgs, for example. Quercetin, Quercitin, 500 milligrams twice a day as a bioflavonoid, which is a very nice antihistamine, neuroprotective, and blocks IL-6, which seems to be the dominant cytokine. It blocks it fairly nicely. Now, quercetin comes co-formulated with bromelain quite often, so don't be confused if you go looking for it. And I don't care.
Okay to take it with bromelain as well?
I'm fine with it, either way. And then finally, nattokinase, 200 milligrams. It comes as 50, 100, 200. If it's derived from enzymatic action by a bacillus species on soy. And it's a mild fibrinolytic, but it is a pretty potent inhibitor of PAI1. Now, if you have trouble with soy, you can easily find non-soy-based nattokinase. Just go on the internet. I think it's ultra nattokinase or something. So with that cocktail, you've got some antioxidant properties, obviously with C. You've got immune stimulation with D. Zinc has some antiviral properties. Quercetin is anti-inflammatory antioxidant and mainly blocks IL-6, and then nattokinase does its thing. So it doesn't say that you won't get COVID, but it should be mild and everything else equal, and you should be at very low risk to go on to coagulopathy complications.
So that would be a preventive regime rather than taking when you think you've got it.
Right. So a lot of people taking 3 of these supplements anyway, you know?
Absolutely.
A lot of people taking, you know, 2 or 3 of these already. So,
one rather personalized question here. My son had a confirmed Lyme infection, and I suspect I was exposed too. What are the reasons for a lack of fever response to infections such as COVID-19? If the illness was still moderate to severe in terms of breathing difficulty and pain, but lacking any fever, only night sweating was triggered.
well, I can't say for sure, but I suspect the hypothalamus is involved here
Okay.
as a result of Lyme infection. So,
Yeah, you mentioned that earlier in relation, I think, to the testosterone. Well, I think we're coming to an end now. It's already been almost an hour. So
it's gone very quickly.
Yes, rather than going on to the further questions that have come in, I just wonder whether there are any additional comments you'd like to make going forward relating to both of these pandemics, and of course the third pandemic, HIV/AIDS, which only you really are truly qualified to speak to.
This is my third pandemic. Much more involved with the first two, but I have to pay a lot of attention to this one, and happy to do so. I just feel honored to be in this place in history where I've been, able to contribute. And the first two are marginalized. This is not so marginalized, right? So they're different. And I appreciate the opportunity to discuss some of the nuances of this disease, and particularly LBC, where I think there's so much material and so much information that I hope to put out. That's why I'm doing live stream every month, because there's no end to questions or nuances.
Just to mention, Lyme BC, Lyme Borreliosis complex. Yeah. That's your specific term for.
Yes, exactly. Well, yeah. So some people don't like the word Lyme, but I mean, we need Lyme in the Google world. Borreliosis complex has many meanings. It means multiple pathogens, multiple systems, and so forth and so on. So it means other pathogens. And but at any rate, I'm honored to be able to contribute, and happy to do so.
Thank you so much. Well, that was an absolutely fascinating discussion once again, Dr. Jemsek. Thank you so much. Hope to have you on again with us soon. The live streams that you're doing, I'll mention, I think others can probably look out for those, can't they, if they sort of Google what you're doing on the web.
Right, they're on Facebook.
Maybe mentioned on your website as well.
Yes, website, and they're on Facebook.
Fantastic, thank you. So thank you very much, everybody, for taking part today. And just to mention that we will be having further webinars of this kind. We're starting up a sort of mini series on cancer and the associated issues. We hope not to have to involve COVID-19 in that, though who knows, it's very difficult to predict, isn't it? And also PANS, PANDAS, which Dr. Jemsek, I'm sure you do find you get involved with as well. Do you want to say just a few words about that, or is it difficult to mention anything related to COVID?
No, I think it's an overlap with LBC in the spectrum. I do. I think the cingulate gyrus is involved along with the brainstem, and I think that I met with Dr. Cunningham and AONM, I believe. She's a lovely lady, lovely person, very smart, and I think the whole streptococcal thing is a molecular mimicry having to do with cellular turmoil and the immune system being confused. Because if you had a primary streptococcal infection, you would die. Knowing what I know about streptococcal infections. But I think it's real. I think it's just, again, about where, in a genetic sense, what part of the brain is involved to lead to OCD and, that sort of thing, which is a trademark of this, and ADHD, a trademark of this. So, but I think it's in the spectrum of LBC, quite honestly.
Wow. Okay. Well, thank you very, very much again, Dr. Jemsek, and thank you everybody for joining us today. And any further questions that haven't been answered, we will obviously keep and either answer direct if we can, or put to Dr. Jemsek the next time we see him. Thank you very, very much.
Good to see you, Jillian.
Thank you. And can we find out more about your Global Lyme Alliance study from your website and the Facebook as well as it proceeds?
Yes, we'll be posting, but we have, you know, that's kind of not my call. That's up to the monitors who let me, you know, tell me what I can say and what I can't say.
It is very encouraging, though. Thank you.
Yeah, it's very exciting.
Bye-bye then. Thank you very much indeed. Bye-bye.
Bye.